Hi, I'm Brennan Spiegel. I'm a physician and a gastroenterologist and a professor of medicine at Cedars-Sinai here in Los Angeles. And what I want to do for the next 20 minutes or so is see just how well this OpenAI chatbot is able to answer medical questions from a board review book that I wrote many years ago. It's a series of books that are used to help doctors prepare for the GI board exam. And so what I did is I took a series of questions out of these books, and I'm going to pose them now to the computer, and we're going to see how well it does. So let me start by opening this thing up so that you guys can see what I'm talking about. This is the ChatGPT interface. Those of you that have been working with this or testing it out have seen that this is a pretty amazing platform. As it shows on the screen, you can ask it to explain quantum computing or give some creative ideas for a 10-year-old's birthday or have it write some JavaScript for you. It does a lot of pretty incredible stuff. So what I want to see today is how well can it compete against doctors answering questions that I give it just straight from the book that I wrote. All right, so let's start. I'm going to just pop this thing right in here right now. I'm going to start with a 22-year-old woman who presents with repeated episodes of regurgitation daily for the past 3 years. These are postprandial effortless symptoms, usually preceded by belching. She has postprandial fullness. She has not lost weight, no heartburn, nausea, dysphagia. She has gastroesophageal reflux disease, or GERD, that did not respond to proton pump inhibitors, has a normal upper endoscopy, manometry, and other studies. So the question here is, what is the diagnosis? Now, most gastroenterologists should know the answer to this. The question is, does the computer? So let's hit it. And here it goes. Right away, it's giving a response. It says it's possible that this woman is experiencing symptoms of a condition known as rumination syndrome. Well, that's exactly right. That is, in fact, the correct answer. So the computer is 1 for 1. As it says, this is a condition characterized by episodes of regurgitation, which are typically effortless, occur soon after eating, and so on. So 1 for 1, that's not a very difficult question, but, it's not a question that everyone knows the answer to. Mostly, this is for a more subspecialty crowd. So I think that's pretty impressive. So let's say it's 1 for 1. All right, let me go now and give it a second question here. I'm going to pop this one in. This is a 32-year-old male who presents with a history of recurrent vomiting. Now, this one's a little bit trickier. He describes a column of fleshy tissue that snaps out of his mouth like a lizard's tongue after vomiting and then snaps back in again. Now, anyone who's taken my board review course or maybe read the books probably knows the answer to this one already. And even if you haven't, this is sort of a characteristic question that might show up on a board review or board exam. Now, on a few occasions, alarmingly, he describes choking on this tissue. So the question is, what could this be? Let's see how the computer does with this one. Right away, it's very confident. This individual may be experiencing esophageal prolapse. This occurs when muscular tissue that forms the wall of the esophagus becomes weakened, allowing part of the esophagus to protrude through the mouth. This protrusion can sometimes occur after vomiting. Wow. So I don't think I've actually personally seen a case of the esophagus itself prolapsing. Be curious in the comments if anyone has seen that before. What I have seen is a polyp, fibrovascular polyp, a large polyp that can form like a wrecking ball and cause choking. And that would be the correct answer for this question. So, I don't think I'm going to give it credit for this one. Maybe I need to brush up on, maybe it's teaching me something, but I got to tell you, that is definitely not the answer to the classic board type of question. And I've not seen the actual esophagus prolapse out. I've seen polyps within the esophagus prolapse, and that's really what we're looking for here. So I'm going to say it's 1 for 2 so far. Okay, so that's not quite clear to me. All right, let's see what the next question is that I'm going to give it. Pop this here. This is a 72-year-old man with recent onset dysphagia for solids and liquids. So it's a recent onset, and that means this patient can't swallow. For those of you that maybe aren't physicians, This came overnight, and that's a key clue. We're going to see if the computer can figure that out. Like, he was fine, and then all of a sudden he's having trouble swallowing. He also has constipation at the same time. And that's interesting because why would those co-occur? Makes you start to wonder. He's not on any new medications. He's not had any alarming features like rectal bleeding, abdominal pain. He doesn't have symptoms of CREST. So physicians know that's part of systemic sclerosis. So it shouldn't be telling me that's the answer. He, and very importantly, has been smoking a long time and recently has had a worsening cough and hoarse voice. That's a bit worrisome for maybe cancer. He undergoes an upper endoscopy. It doesn't find a lesion. There's no cancer in the esophagus. What condition should you be worried about? And how can we test for it? All right, so this is a little bit of a tricky one. This is also very common, common for board review. And let's see, can the computer handle this one? It's thinking, all right, based on the information provided, this patient may have laryngeal cancer. This type of cancer occurs in the larynx and can cause symptoms like dysphagia, hoarseness, and coughing, and can occur with tobacco use. Okay. And so this patient needs a laryngoscopy, and that's when you stick this camera in and look around. And this answer is wrong. Okay, this is not correct. First of all, it's really not seeing the big picture here. It focused in clearly on the fact that this smoker has a hoarse voice, and that's thoughtful. It's certainly, I'm worried about laryngeal cancer. I'd have to say, we did just stick a camera down already, although it wasn't a laryngoscopy. We certainly can see the larynx as we pass through with a camera, which we already didn't see obvious cancer. It's definitely worth thinking about that this patient also has new onset constipation, and this happened overnight. You know, laryngeal cancer doesn't just happen overnight, and it's not clear why that would cause constipation. This is actually a paraneoplastic syndrome from lung cancer. And there's an antibody, the anti-Hu antibody. It's a little bit of a scholarship question that we might check, but what this patient really needs is a chest x-ray to see if there's cancer. I wouldn't go to laryngoscopy first. Could this patient have laryngeal cancer? Sure, but it doesn't really fit the facts in this case. So I'm going to say this is wrong, and the computer, I think, is now 1 for 3, if I'm following that correctly. All right, so what's next on my list here? Let's see here. All right, 83-year-old man with longstanding dysphagia. He's another case. Now, these questions are all from kind of the foregut, esophagus, and I'm keeping it thematic. I might do some more of these depending on how this goes. So 83-year-old with longstanding dysphagia, can't swallow. Solid food is intermittently stuck in the back of the throat as he's trying to swallow. That's kind of interesting. It's stuck in the back of his throat. All right, that could mean a lot of different things. He has no problems with liquids. Not sure if it's a motility problem. He does have a history of osteoarthritis and repetitive traumatic neck injuries. Now, for a gastroenterologist, those are kind of buzzwords. That means this person may have something going on in their neck, and that may be causing a problem, maybe even some compressive problem. And so we do an upper endoscopy to look at the camera, which is appropriate, and doesn't find an obvious lesion. So there's no cancer there, no inflammation. And that's sort of what's shown. So what's the most likely diagnosis here? Well, let's see how it does on this. Okay, this patient may have a Zankers diverticulum, which is a pouch in the wall of the pharynx near the junction of the esophagus. And that's seen in older individuals, and this is in older individuals. So that's not a bad idea. And maybe associated with a history of neck injuries or conditions that affect the muscles in the neck, such as osteoarthritis. That's interesting. I haven't seen personally, maybe I have missed this. I've not seen osteoarthritis causing a Zankers diverticulum. And so maybe from a laryngoscopy or barium swallow. All right, well, it's not like it's that far off, but it's kind of missing the diagnosis, at least that I was thinking of. And that when we pose this question, doctors almost immediately get, and that's a cervical osteophyte. This is a consequence of repetitive neck trauma where there is a lesion, an osteophyte that forms off of the cervical spinal column and the vertebral bodies that can compress into the esophagus. They feel like there's something caught in the back of the throat. I'm not hearing about classic Zankers symptoms like halitosis or bad breath, or food coming back up again. Like those would be kind of classic Zankers type of historical piece. Yeah, so I don't know. I don't think that's the best answer. It's not like it's wrong, but it wasn't one of those sort of read my mind. I'm seeing it's not great at kind of reading the mind, whereas the doctors, when I pose this question, I don't think I ever hear people say Zankers. They usually jump right at cervical osteophyte. So maybe it's 1 for 4. Maybe I give it half credit for that, because it's not terrible, but it's not really what I was looking for. All right, let me try another one. So here is a 52-year-old man with pemphigus vulgaris with chest pain and vomiting. He reports vomiting a long white tube of tissue. So that's an interesting feature, quite characteristic of this pretty rare condition. So this is not an easy question. But when I pose it in our board review sessions, doctors tend to get this one pretty quick. Now, here's what really gives it away. Upper endoscopy reveals sloughing of longitudinal strips of epithelium. What is this condition? Okay, let's see what it says. All right, maybe experiencing esophageal candidiasis. Oh, God, no. This is an infection of the esophagus caused by fungus. Yeah, it's people with a weakened immune system. Okay, like those with pemphigus vulgaris. All right, I don't know. That's not at all what I'm looking for. Yeah, of course, Candida can cause some white, lesions in the esophagus, pretty characteristic. I've never heard of somebody with esophageal candidiasis vomiting a white tube of tissue, and it would not appear as sloughing longitudinal strips of epithelium. Not in my experience. I've never seen that. This is actually called, this is actually esophagitis dissecans superficialis. That's what this is. This is a consequence of various conditions. So it's associated with pemphigus. It's been associated, I think, with celiac disease and other conditions. But this is definitely not candidiasis. So I'd say it's 1 for what have I lost track of. It's gotten a 1 right so far. Out of, we had 4 or 5. I'm losing track. All right, what's the next one? So it's got 1 correct. Here's the next one. Follow along at home. This is a 36-year-old healthy woman with a 6-year history of progressive dysphagia. So again, I'm sticking with these esophagus questions for now. Referred to for evaluation, a barium esophagram reveals. This is a classic one. Okay, a little tricky. See how these are a little bit tough. Reveals an oblique tubular defect at the upper thoracic level, just above the aortic arch. What might be causing this? So this is one of these classic board style questions. And again, when I pose this to doctors, they get it. They love this one. If you're following along as a GI doctor, you may be thinking, what is this? If you're not sure, you may know. Well, let's see what the computer says this is. Okay, this patient is experiencing, oh man, this computer loves Zankers diverticulum. Pouch-like structure forms in the wall of the pharynx and so on. Going to get a barium esophagram. All right, well, that's not what I was thinking of. Again, is it totally wrong? Well, certainly not reading my mind, so to speak, but that is not what I was looking for. What I'm looking for is actually a vascular anomaly. Let me see if it's just maybe the way I wrote it. I'm going to pose it again, but this time I'm going to say what vascular anomaly might be causing this. I'm going to give it another hint. Let me see if I can give it a hint. Okay, let's see if that changes it. Oh, an aortic aneurysm. Wow. The aorta becomes weakened, bulges. It could potentially cause symptoms like difficulty swallowing. That's true. That's true too. Still not quite getting what I'm looking for. So if you're following along and you're a GI doctor, you may know the answer. It's dysphagia lusoria, which is an aberrant subclavian artery, right subclavian artery that actually traipses across from left to right behind the esophagus, compresses it. It's a tubular diagonal structure. Missed it. That's definitely not what I was looking for. Is it totally wrong what the computer saying? That's a little tricky, but I'm not going to really give it credit for that. All right, let's keep moving. I'm going to give it another one. Let's see what happens here. All right. So 50-year-old woman presents with progressive dysphagia. Again, I'm sticking with these swallowing problems for this session. Difficulty standing from a seated position. Okay, that's a very characteristic feature of this condition I'm thinking of. Computer hopefully is catching on to that. Describes a violaceous, I spell that right? Violaceous rash, like a shawl. Okay, there's a shawl type of rash at the nape of her neck. So that should be enough to get this condition. Can't stand up from a seated position, having trouble swallowing, shawl at the nape of the neck. What is going to be? So here's one of these tough questions called a second order question for doctors. It's not what is the diagnosis. Okay, the question is, what would you see on manometry? So it requires that you know the diagnosis. That's the first order, but that's not the question. The question is, what are you going to see on manometry? That's the second order. So let's see if it can catch this kind of tough question here. All right, this patient has scleroderma. No, this is not scleroderma. Chronic autoimmune disorder. Seems pretty confident, though. It's like, yep, scleroderma. Possible. I mean, it's hedging a little bit. And it goes on to explain it's often associated with the Schall sign. Is scleroderma often associated with the Schall sign? No chance. I mean, I hope I'm not wrong about that, but I cannot have to look it up. I'm not opening up the internet here. But my own memory banks, I don't remember seeing Schall sign associated with scleroderma. The Schall sign is worrisome because that could be a paraneoplastic syndrome of some cancer, potentially. And this condition is actually dermatomyositis, and it's a myopathy, which is why this patient is having trouble standing up from a seated position. And that's not specific for scleroderma, nor is Schall sign. And certainly dysphagia can occur with scleroderma, but it's kind of missing the point of this question. I don't know, I have to write it differently. And it goes on to explain what you do to diagnose scleroderma, but it's already off the beaten path. That's not right. I mean, not what I'm thinking of. So, we can get into the details of what manometry would show for dermatomyositis, which is a proximal 1/3 myopathy of the esophagus, but the computer's like way off, chasing down scleroderma. So not what I was looking for. So I think it's gotten one question right so far. All right, what's the next one? Okay, this one it should get, I hope. This is a pretty straightforward question. Let's see how it does on this one. 32-year-old. Well, I'm laughing because I'll tell you why in a second. With progressive dysphagia again, first for solids, then for solids and liquids. She has a megaduodenum and on small bowel follow-through and recurrent bouts of small intestinal bacterial overgrowth. Okay, this is one of those things like doctors get. And I'll laugh if it doesn't get this right for a reason I'll tell you in a second. Let's see what it says. Okay, it's possible this individual has symptoms of a condition known as intestinal pseudoobstruction. Oh man, I guess, geez. Well, this thing, man, it said scleroderma over and over again when it wasn't supposed to say scleroderma. And this time, when I really wanted to say scleroderma in a younger woman with progressive dysphagia, megaduodenum, and SIBO, that's scleroderma, like on a board exam. That's I would not be thinking about intestinal pseudoobstruction. That's not really the best individual. I mean, I guess so. I mean, it's a condition where there's sort of essentially a paralysis of the small bowel, and it can present with a megaduodenum. It's not clear to me why that explains dysphagia in the absence of scleroderma. So it's sort of reaching on that one for me. I'm not giving it full credit for that one. Maybe disagree. Feel free to let me know if I'm getting something wrong here, because I'm not checking, textbooks. I'm referring to my head here as I'm thinking of this, but maybe it knows more than I do, but I don't think that's the best answer. Okay, I gave it another one while I'm talking. This should get. 42-year-old with renal transplant who has dysphagia, odynophagia, epigastric pain, 2 large irregular ulcers. Biopsy reveals large inclusion bodies. What condition is most likely? This patient may have cytomegalovirus, CMV esophagus. Exactly right. Yeah, this one's pretty straightforward. I could have said owl eye inclusions, which would have really given it away, but I didn't. I wanted to make it a little bit trickier. This one I had no problems with. So it's gotten this one correct, definitely right. This one, I think most every GI doctor would get. I mean, almost everyone's going to get that one right. So it got that one right. All right, let's move on. Here's another one. It's a little bit more kind of like guideline based. 56-year-old male with longstanding GERD undergoes an upper endoscopy. That's what EGD is for short. I'm assuming it knows what that is, which reveals a C1M4 distribution. So I'm going to see if it understands what C1M4 is. That's a sort of a detailed way of evaluating Barrett's esophagus distribution. I won't go into the details right now what that means. I want to see if it knows. Salmon-colored mucosa, so that's code language for Barrett's, in the distal esophagus. 4-quadrant biopsies are performed every 1 centimeter. Pathology reveals intestinal metaplasia, but no dysplasia. Okay, the question is not what's the diagnosis, it's Barrett's esophagus, but the question is when should you perform your next upper endoscopy? All right, so this is more of a guideline type question. Let's see if it understands what this is about. Okay, it's possible a patient has Barrett's, very good. And explains what Barrett's is. It's associated with GERD, good. And it says it's, indicative of Barrett's. It knew what salmon-colored mucosa was. To recommend they undergo periodic surveillance with upper endoscopy. Exact frequency should be performed, may vary, but typically every 1 to 3 years. Didn't quite turn the corner on that one. No, I mean, it was right all the way through, but then it said every 1 to 3 years. Actually, this patient is at pretty low risk, does not have dysplasia, just has sort of run-of-the-mill C1M4 Barrett's without dysplasia. Now I'm even wondering, God, do I have it wrong on my head? No, it should be like 3 to 5 years. 3 to 5 years, not 1 to 3 years. Nope, that's wrong. Okay, so wrong again. Seems to need some work. It's like nibbling around the edges pretty well. Here's a 17-year-old. Okay, a lot of clues here. 17-year-old, a recent immigrant. So assuming we're here in the United States, seeing a patient in Southern California where I live, we might see somebody who's come from Mexico, who has difficulty swallowing solids and liquids. And that's relevant, as we'll see in a moment. Symptoms began 3 months ago. She recalls swelling around her left eye prior to the onset of the symptoms. That's a characteristic clue. She's been living in a thatched roof hut in Mexico. That's another clue for this condition, kind of textbook type of buzzword for board review, which is most likely to be seen on esophageal manometry. So a tricky question. First, you need to know, first order, the diagnosis. Second order is what would you see on manometry? So this is a question I might pose to my students. And let's see what they say. Okay, Chagas. Okay, very good. That is absolutely correct. This is indeed Chagas disease, which is a tropical parasitic infection caused by Trypanosoma cruzi. Yeah, it's can cause swelling around the eye. It's found in Latin America, including Mexico, and so on. And there's different tests you might do, including manometry. And so they review abnormalities, which are shown here. Reduced muscular contraction. Okay. I would have liked a little more detailed answer for the manometry findings to give full credit if this were a doctor. It's sort of an achalasia-like picture. It doesn't say that, but I'm going to give it credit because it got the diagnosis and got most of this right. All right, let's give it a few more. Let's see how it does here with this next one. I'm going to give it a full, maybe 16 question test, and we'll see how it does. I think it's gotten, I've lost track now. I'm not writing it down. Has it gotten 2 right? Maybe 3 right. I think it's gotten 3 right. All right, 22-year-old with dyspepsia, recurrent nausea and vomiting, progressive weight loss, lower extremity edema, no fevers, lymphadenopathy. All right, here's a tricky one. I mean, it's not a common condition. Gastrin is not that high, a little elevated. And so it only increases from 230 to 250 with a secretin stimulation test. So that is characteristic to rule out a certain condition. Albumin is low. That's interesting. There are thick gastric folds. There's mucus everywhere in this young person. What's the diagnosis? And what histopathologic finding is going to be seen on biopsy of the actinic gland mucosa? All right. This is a fun question for students who are learning this field. Let's see how this computer does. This is a pretty characteristic feature. This patient may have Zollinger Ellison syndrome. No, that's not right. I mean, it's not totally wrong to think about Zollinger Ellison syndrome. It's going on and on about ZES now, and what it's good. No, this actually, this is Menetrier's disease, which is a pretty unusual condition. Don't exactly know what causes it. See, with Zollinger Ellison, first of all, you probably see a much higher gastrin, often 1,000 or higher. But if it is less than 1,000, you should see a much larger increase in gastrin with a secretin stimulation test, really at least 100, 150, 200 point increase with the secretin stim test. Here it went up by 20 points. That's not pathognomonic of Zollinger Ellison syndrome. The low albumin is, I guess, not specific, but you see a protein losing enteropathy with this condition. Menetrier's disease and the thick gastric folds in the mucus. You would see foveolar hyperplasia. That's not seen here. I think this, I'm not giving it credit for this. It's wrong. All right, so overall, not seeing it do a great job. Let me see just a few more here. Here I'm giving it one with a gastric tumor, 4th layer of the stomach. FNA is performed, fine needle aspiration. And it's positive for smooth muscle, actin negative for CD117C kit, S100 and Vimentin. What's the tumor? All right, what does it say? This patient may have a gastric leiomyoma. Oh, very good. That's very good. Yeah. Benign tumor, smooth muscle, absence of CD117. Very good. And S100 and Vimentin may also be indicative of this type. Yeah. This is, in fact, a gastric leiomyoma, not a GIST. Not a schwannoma, not a glomus tumor. So yeah, this one I got right. I got that one right. It's interesting. If I give it kind of specific, maybe it's how I asked the question. I'm not sure. Let me give it another one. Here is this is a kind of a little bit tricky one, but there should be enough clues to get this. 52-year-old with Hashimotos thyroiditis. Okay, that's important note for those of you that are using this for board review yourself. So there's an autoimmune condition in the mix here. Now with dyspepsia, you refer to rule out Zollinger Ellison because somebody checked a gastrin and it's very high. So now you're like, oh, that could be Zollinger Ellison because it's very high gastrin, but other things cause a high gastrin, not just Zollinger Ellison syndrome. Endoscopy is performed. There's no ulcers, which kind of argues against Zollinger Ellison, but there are some small carcinoid tumors, okay? And a secretin stim test is performed, which is negative. So as we said, that kind of rules out Zollinger Ellison right there. What condition are you most concerned about? What would pull this all together with Hashimoto's thyroiditis and carcinoids and a high gastrin and dyspepsia? Okay, let's see how it does. All right, it's thinking. Did I stump it this time? All right, well, as it's thinking, let's think about what's going on here, because this patient has an autoimmune condition, and you got to think about what else can be causing a high gastrin. This patient may have MEN1. That's not where my mind was going. Genetic condition, tumors can cause high gastrin. You could see carcinoids with MEN1. Well, it's not really explaining the Hashimoto's thyroiditis. And that's sort of the key here. Maybe it needs a little bit more data, but when I show this to like humans, they think, this could be pernicious anemia. And that's what I'm thinking of here. That's an autoimmune condition of the stomach where you have an atrophic gastritis of the stomach and reflex hypergastrinemia in association with other autoimmune conditions. MEN1 is an inherited condition. That's not an autoimmune condition. I'm not an endocrinologist, but I think it checked me on that. I don't think MEN1's autoimmune condition, not what I was thinking of. Again, it's sort of like in the ballpark, but not really what I was thinking about. All right, a few more, then we'll call it. Let's see how it's doing here. This is a pretty straightforward case to me. 62-year-old woman has a peptic ulcer hemorrhage on aspirin, receiving aspirin, that's ASA, see if it knows that abbreviation, for secondary prophylaxis because of hyperlipidemia, hypertension, and previous myocardial infarction. So what we're saying here is this patient has been pretty affected by cardiovascular disease, really needs to be on that aspirin. But unfortunately, she has a bleed while on aspirin. So she is successfully treated with endoscopy and hemostasis, has an actively spurting vessel, receives appropriate treatment with an intravenous proton pump inhibitor. She's now being discharged. When should she be restarted on aspirin, if ever? Okay, we'll throw in a little bit of a twist there. This patient needs to be on aspirin, all right? But let's see what the computer says here. And then this, by the way, the answer to this question has changed a bit since when I was a trainee. When I was a trainee, we might not have started this patient right back on aspirin, worried that it was going to cause more problems. But since then, we've come to realize this patient needs to be on aspirin. So, oh my goodness, it's likely this individual should not be restarted on aspirin. Aspirin is a common cause of ulcer bleeding, and it can increase the risk of an individual who are already at high risk. This patient should avoid taking medication. Oh, shoot. Now, this is dangerous. I mean, literally dangerous. Like, this is a big issue because there are randomized controlled trials showing what happens in a patient exactly like this if they're randomized to be put right back on aspirin or not put back on aspirin. And guess what happens? Well, there's no difference, statistically significant difference in the incidence of GI bleeding in those groups. But what does happen is there is an increased risk of mortality in the group that is not put back on aspirin. This is dangerous. I think I need to let them know about this one. That's a problem. This would be wrong and medical legal risk if you don't take a patient who has been on aspirin for a heart attack, gets treated, and you don't ever put them back on aspirin again. That's a real issue, real issue. All right, I have one more to give it. That last one really bothers me. Here's a long one. Let's see, 72-year-old with pretty much with heart failure, okay, and diarrhea. So right away, if you're a doctor, you're thinking, what's my differential diagnosis for heart failure and diarrhea? So has been going on for 6 months. This patient has had nausea and vomiting and abdominal fullness. So something's going on in their belly, maybe related to the heart failure. Has crackles in their lung base and a large soft liver with hepatojugular reflux. All this is showing us that fluid is building up in the body, shifting dullness, lower extremity pitting edema. Doesn't have chronic liver disease, does have a low albumin though, high alk phos, high AST, ALT, INR is normal. So liver function seems to be okay, but the liver is probably full of fluid. All right, so we get called in GI, we put an enteroscope down, we see focal white spots throughout the visualized duodenum and jejunum. By the way, it's duodenum, not duodenum, but that's another story. Biopsies of these lesions reveal dilated lacteals, very specific. Okay, so most GI docs will know the answer to this one. What is the diagnosis? Okay, it's thinking. I don't know if the server is getting overwhelmed now or it's just like had enough of me. By the way, this is all one continuous thread. So the neat thing about this is it is paying attention to the previous answers. That might be affecting how it approaches the new answers. So this patient may have protein-losing enteropathy, conditions where the intestines are unable to properly absorb proteins, leading to symptoms such as diarrhea and weight loss. It is commonly associated with heart failure. And enteroscopy can see focal white spots, can be indicative, dilated lacteals. Okay, well, that's interesting. I'm going to give it credit. I was thinking the answer is lymphangiectasia, and I think most doctors would have gotten that. But lymphangiectasia is a form of protein-losing enteropathy. So I'm going to give it credit, although it didn't give me the word that I wanted. I would have liked to have heard it say lymphangiectasia, because that's what it is. But it's giving me a perfectly, I think, a good enough answer. So that's my last question. I gave it 16 questions, I think. I lost track, but I want to say I got about 4 of them right. Maybe 25% right on this quiz. Maybe it got 5. Have to go back and watch the tape. Not great, not great at all. And so what does this teach me? I mean, it's new. I mean, this system needs to be trained. It's giving very confident answers. I mean, it's saying things like based on the information provided. So it's got some caveats. But overall, it's kind of missing the forest for the trees sometimes. There's certain questions that it gets sort of right away, like rumination. It got those buzzwords. It knew, I don't know, I'm trying to remember now. It knew a bunch of other things here, and not a bunch of other things. It kind of came close. It knew a leiomyoma. That was good. But there were certain things that knew Chagas disease, okay? But like, it would know that there's Barrett's esophagus and then give the wrong surveillance interval. It would know that aspirin's bad for the stomach, but make the mistake of saying to stop aspirin and somebody for whom it may save their life. We always say in GI that the heart is more important than the gut. You can die of a heart attack. It's become unusual to die of a GI bleed. No one wants that. but we can manage it. So these are things the computer's missing, and that's a little bit troubling. So I'd say it needs some work. It's definitely not going to pass the GI board exam, not even close. It's not outperforming any doctors at this point for these kinds of questions. I understand these are kind of archetypal board type questions. Maybe there's a little read my mind in there, but that's what humans do. Is the humans, when they hear these questions, they get the answers pretty fast. This computer's not getting it fast. So maybe I'll do this again with another set of questions as it continues to learn and try a different area within gastroenterology. So far, not super impressed, but still overall an amazing system. For other things, don't make life or death decisions on the basis of this thing. And I'm sure the developers would be the first to tell you that too. So doctors, we still need you. We're not going out of business yet. But let's see, as this progresses, how much smarter, so to speak, this AI gets. We like to think of AI not as artificial intelligence, but as augmented intelligence. Hopefully it can augment how we do our work. But as of right now, in this little 16 question quiz, it needs more augmenting. So hope you found that useful. And until next time, keep testing it out and telling them what they need to get right. All right.